All right, let's dive right into this explainer and demystify the complex medical reality of ischemic strokes. We often hear the word stroke thrown around as if it's just this one single monolithic condition. But the reality, it's actually much more intricate. Today, we're going to examine the exact mechanisms and locations where these brain attacks occur, and we'll build out a comprehensive investigative taxonomy to really understand the different types of ischemic stroke. Here's the roadmap for our investigation today. We'll start with the anatomy of brain attacks, move into large artery atherosclerosis, check out cardioembolism, examine small vessel lacunar strokes, and finally look into cryptogenic and rare causes. Section 1. The anatomy of brain attacks. Setting the scene.
First things first, we've got to define our focus here. An ischemic stroke is a central nervous system injury caused by a loss of blood flow. Now, this is distinctly different from a transient ischemic attack, or TIA, which resolves in less than 24 hours. Unlike a TIA that just kind of comes and goes quickly, an ischemic stroke represents a sustained, damaging loss of blood flow to the brain, most often due to an arterial thromboembolism. It's this specific lack of oxygenated blood that leads to the catastrophic tissue damage we associate with the disease.
When you look at the global data, the sheer scale of the issue becomes incredibly clear. Ischemic strokes are by far the most common, accounting for a staggering 80% of all stroke events. The other 20% are hemorrhagic types, so that's your primary intracerebral and subarachnoid hemorrhages, which involve actual bleeding rather than blockages. But today, our focus is entirely on that massive 80% slice, the ischemic blockages. Zooming into that massive 80% slice reveals our roadmap of suspects. Based on the widely used TOAST classification system, we can divide these blockages into specific subtypes. Roughly half of all ischemic strokes are caused by large artery disease, a quarter by small vessel disease, and a fifth originate directly from the heart as cardioembolic events. And finally, about 5% remain cryptogenic or have rare causes. Section 2. Large artery atherosclerosis, the main water supply. The journey of one of these clots is fascinating yet incredibly dangerous. It usually kicks off with atherosclerosis, basically a fatty lipid-rich plaque building up in a major vessel and causing stenosis or narrowing. But here's the thing, it's not just the narrowing that's the problem. The real danger happens when this plaque ruptures or fissures, exposing the inner, cheesy material to the bloodstream. Platelets in the blood absolutely love to adhere to this exposed material, and they quickly form a thrombus or clot, anchored by a fibrin mesh. Finally, a piece of this clot, an embolus, breaks off, travels, and completely blocks a downstream cerebral vessel. So where does this usually happen? Well, the prime targets for these blockages are the extracranial and intracranial internal carotid artery, the proximal middle cerebral artery, and the posterior vertebral and basilar arteries. The crucial takeaway here is that these large vessel thrombi typically form at major arterial bifurcations, essentially the forks in the road where vessels split. When a blockage happens at one of these main junctions, it cuts off a massive amount of blood flow to significant territories of the brain, leading to profound neurological deficits. Section 3. Cardioembolism, the heart source. Now we're investigating debris pumped directly from the body's central reservoir. There are several major cardiac sources to look out for here. If a patient has an irregular rhythm, like atrial fibrillation or a dilated left atrium, blood can kind of pool up and form clots. Other high-risk sources include mechanical prosthetic valves or a recent myocardial infarction, a heart attack, which can lead to a left ventricular thrombus or a segment of the heart wall that just doesn't move properly. Any of these conditions can create a clot that literally gets launched out of the heart, up the aorta, and directly into the cerebral circulation. What's super interesting here is the diagnostic approach. To find these specific cardiac culprits, clinicians can't just look at the brain. They have to act like detectives, using transesophageal or transthoracic echocardiograms, along with prolonged telemetry monitoring. They're actively hunting for structural defects or hidden arrhythmias in the heart that might otherwise go completely unnoticed right up until they cause a devastating brain attack. Section 4. Small vessel lacunar strokes, the blocked housepipes. Okay, let's shift gears. Deep inside the brain, we encounter a completely different mechanism, lipohyalinosis. Unlike the large fatty plaques we were just looking at, the tiny penetrating arteries deep in the brain suffer from this specific degenerative change. Lipohyalinosis is a destructive lipid accumulation and thickening of the small blood vessel walls. And what drives this? It's strongly associated with chronic, unmanaged hypertension and diabetes. The high blood pressure and high blood sugar essentially degrade the integrity of these tiny vessels over time.
Take a look at the bright spot pointed out on this MRI scan. This is exactly what a classic lacunar stroke looks like. Because the occluded vessel was so tiny, the resulting infarct is typically less than 1.5 centimeters in diameter. It's this tiny, isolated pocket of damage localized in the deep subcortical structures of the brain, like the basal ganglia or the internal capsule.
Clinically speaking, the difference between these stroke types is night and day. A large artery stroke causes massive cortical deficits. We're talking patients completely losing their language abilities or higher cognition. But a small vessel lacunar stroke, it's different. Because these strokes pick off such small, highly specific, deep-seated structures, patients might experience severe isolated symptoms, like pure motor weakness on one side of the body or pure sensory loss. But crucially, their higher cortical functions, like language and memory, are often perfectly spared. It's a highly localized neurological hit. Section 5. Cryptogenic and rare causes, the unsolved cases. This brings us to a really compelling question. What happens when the source of the stroke is completely invisible? Seriously, despite extensive diagnostic workups, the brain scans, the vessel imaging, the cardiac echoes, up to a third of strokes initially lack a clear, obvious origin. This forces medical detectives to look for rare, hidden, or highly complex mechanisms. When traditional scans show absolutely nothing, physicians use a specific diagnosis, ESIS, or embolic stroke of undetermined source. This designates a non-lacunar stroke where standard testing has officially ruled out large artery disease and obvious cardiac sources. It implies that there's a covert embolic mechanism at play. They suspect hidden issues, things like non-stenosing plaques that aren't quite large enough to catch the eye, silent cancers causing the blood to become hypercoagulable, or even hidden arterial dissections. Let's trace one of the most wild, unlikely journeys in the human body, the paradoxical embolus. It starts with a routine blood clot in the leg, a deep vein thrombosis. Normally, this would travel to the lungs, but instead it travels up the inferior vena cava and enters the right atrium of the heart. And here's the twist. The patient has a patent foramen ovale, or PFO. That's a congenital hole between the heart's upper chambers. The clot crosses this hole from the right to the left atrium, completely bypassing the lungs' filtration system, and shoots directly into the cerebral circulation to cause a stroke. Wild, right? So you might be wondering, why does parsing out all this classification actually matter? Because finding the exact specific mechanism is the only way to prescribe the correct targeted therapy. For large artery disease, you might need surgery or stenting to clear the carotid artery. For cardioembolic strokes, strong blood thinners are absolutely essential. Small vessel strokes demand strict blood pressure and diabetes management. And for a cryptogenic stroke caused by a PFO, well, a surgeon might actually go in and surgically close that hole in the heart. Identifying the culprit is literally how we prevent a devastating second stroke. It leaves us with a pretty profound thought. As our ability to continuously monitor the heart and microscopically image the brain continues to evolve, will the unsolved case file eventually disappear entirely? Will we one day reveal that every single stroke leaves a traceable blueprint? Thank you so much for joining me for this explainer, and keep pursuing the knowledge that clarifies the complex world around us.